One more time, welcome everyone to the third lecture of our orthopedic reconstruction review course. We'll speak today about tooth and knee replacement, why and how. My name is Mohammed Hashim. I'm a foot and ankle and trauma consultant in Framingham Health NHS Trust in Northwest London. We've started this course about 2 months ago, and it should be running regularly bi-monthly on Friday, 9 p.m. London time. This is Heatherwood. It's our elective hub where my main practice is, and this is where you can find all the educational activities run by OrthoXcel. It's my educational channel, Hashim's educational channel, and OrthoXcel website, and this is the email if you want to contact me. Good. So if we start with asking why we need a tooth and knee replacement. So you need tooth and knee replacement mainly to control pain of arthritis and to regain function. So what do you need from your knee as a function-wise? So you need at least 70 degrees of knee flexion to be able to walk, and 90 degrees of knee flexion to be able to ascend the stairs, and a 110 degree of flexion to be able to raise from a chair without using the support or to descend stairs. And definitely for squatting or lifting, you need at least a higher degree of flexion, about 117. So that's why without this efficient knee flexion, your daily life will be affected. And this is where you start thinking about the solution for your knee arthritis. And this is when you start to think about tooth and knee replacement. Good. So what's the indication to do a tooth and knee replacement? That's a very important slide, because this is where we start from. So you need a knee replacement to control your pain. So remember that all replacements, all artificial joints or joint replacement are pain management procedure. There is no excuse that you do an operation for a patient who is not an effective, really pain affecting the normal day. Otherwise, your patient will never be satisfied. So if you wait for your patient to be satisfied, the patient has to be exhausted all the non-operative measures, and the pain become uncontrolled up to affecting the normal daily function. So that's why it's 3 times written and it's always underlined. So uncontrolled pain affected the daily function. Uncontrolled means simple analgesia cannot control it. Function limitation could be a reason, but you cannot do an artificial replacement just for functional limitation. Joint deformity, yes, we can correct the joint deformity, but mostly not an absolute indication. We use this just as an adjunct when we're doing a knee replacement or a hip replacement, is to control the joint deformity. When not to do a knee replacement. So definitely if the patient has an active infection, there is no point to put metal or a foreign body inside the patient with active infection. If the patient had a neuropathic joint because there is no proprioception, there is no control, so failure is a must. So you never put the joint in an active infection in a neuropathic joint, or definitely if the patient has a critical limb ischemia, because the surgery itself is a trauma, and trauma of the surgery on top of critical ischemia will end by a more critical ischemia. Relatively, you cannot do a knee replacement if you have an extensor mechanism problem, if you have an arthrodesis before with poor soft tissue, because always remember that the post-operative range is depending on the pre-op range. So if you have very minimal pre-op range and the muscles and soft tissue are contracted around the knee, so don't wait for a good knee range of motion post-operatively. Definitely medical comorbidities, which could be risky when the patient life under anesthesia, and hip arthrodesis, because if you arthrodese the knee, if you replace the knee on a hip arthrodesis, this will be putting more stress on your new joint, and risk of failure will be very high. Okay, if I plan to do a knee replacement for my patient, so the patient have uncontrolled pain, which is affecting the normal daily life, I need to assess my patient properly before the operation. So my advice to you, never do a tooth and knee replacement without having all these pre-op x-rays. You have to have a full length EB view for the limb, both legs. So to be sure that what's the alignment of your limb, because this will manage where will you put your knee, and how can you correct any deformity using your knee replacement. Weight-bearing x-rays, because you need to see the joint in a physiological condition. So if you do a non-weight-bearing, I should get you an image for weight-bearing and non-weight-bearing. Without a weight-bearing x-ray, the joint is not physiologically loaded, so you cannot give a clear conclusion or a clear decision on an unloaded joint. So you have to have a weight-bearing EB and lateral, And for me, the lateral weight-bearing X-ray is very important. As you can see, there is nearly no joint spaces, bone-on-bone arthritis, and this is a clear indication to do a knee replacement. You have to have a merchant or sunrise view for the patellofemoral. You need to know how is your patellofemoral, where is the defect? Is the patellofemoral has a global arthritis or medial or lateral arthritis? Because later on you will know that will judge our patellar tracking and where we put our patella. And again, most importantly, you have to have a Rosenberg view at the 45 degree. So you have a posterior anterior view for the patient, weight bearing and a 45 degree flexion. And this is one of the most sensitive views, which can give you an idea about the joint space. So if there is a subtle arthritis, you can easily spot it from the Rosenberg view. Rosenberg view is the most sensitive to catch any tightness in the joint space or narrowing of the joint space. Okay, so what's the conservative management the patient need to have before we do a total knee replacement? And this is very important for total knee replacement, because we agreed if the patient doesn't exhaust all these measures of conservative management, I promise you this patient will never be happy. And the evidence is supporting this. If you do a knee on a non-indicated patient or patient who can get a benefit from conservative management, this patient will never be happy post-op. And to have a proper conservative management of an osteoarthritic knee, you have to go through all this. So there is a nice guidelines. There is an American Academy guidelines, physiotherapy, especially low impact exercises, quadriceps strengthening, range of motion exercise, bracing if the patient have a unicompartmental, either medial or lateral, weight loss, which is definitely a main factor to reduce the stress over the knee, the analgesia ladder, and intra-articular injection. An intra-articular injection varies between steroids and hyaluronic acid, and we all know the debate about the hyaluronic acid, does it give effect or not. American Academy advised against it, while the nice guidelines still feel it benefit, but with no evidence. Nice guidelines definitely recommend to use a topical non-steroidal physiotherapy, TENS machine, thermo adjunct, but it doesn't recommend glucosamine, chondroitin, or acupuncture. Arthroscopic lavage and arthrolysis can help with the mechanical symptoms. It washes all the inflammatory mediators, so it can give the patient symptomatic short-term relief, but definitely not in an advanced arthritis. So how can you give your patient a happy total knee replacement? That's very, very important as well, because your aim is not to put a total knee, but to give your patient an improvement of pain and function. So patient have to have a happy total knee to be a pivotal point in his life. So to have a happy total knee replacement, you have to restore the mechanical alignment of the limb. So you need to have a long film views for that, to be aware of the mechanical axis of the limb and the anatomical axis of the limb. Your cuts has to be perpendicular on the mechanical axis, and to be careful about the natural internal and external rotation, the natural varus and varus valgus. You need to preserve the joint line, so to maintain the joint line at the same level, so you can maintain your patellar height. So elevation of the joint line will end by a relative patella baja, and the other way around, if you lower your joint line, you end by relative patella alta. So preservation of joint line is very important to maintain the soft tissue tension and to maintain your normal patellar tracking. Definitely balanced soft tissue is a critical point. So to have a happy total knee, there is no happy total knee without a soft tissue balance. And remember, total knee replacement is a soft tissue balanced procedure. With a soft tissue balanced, your total knee will be a very successful one. And how can you balance the soft tissue? You need to have good component rotation, good component position. You have to have a good strength, good strain and tense ligaments. And you have to have a rectangular equal gaps in both flexion and extension. You need to restore the range of motion, and the most important is to restore the range of motion with balanced knee through the whole range, because if you don't have a balanced knee through a full range of motion of the knee, you will have a mid-flexion instability, which one of the causes of unhappy total knee. So to have a happy total knee, you try to get the patient the maximum range of motion, and you have to have a balanced knee ligament through this range of motion. Rotation alignment of the femoral component is critical for the patellar tracking, so and for the rectangular gaps, because as you understand and know, the medial femoral condyle projects more distally and more posteriorly than the lateral femoral condyle. So if you don't maintain a good rotational alignment of your femoral component, you will end by an unbalanced gap which will not be rectangular, will be obtuse in one end and acute in the other end. And at the same time, without proper rotational alignment of the femoral component, if the femoral component is internally rotated, this will predispose your patella to maltrack and to be laterally dislocated. You have to restore the Q angle, and again, the Q angle is very important for patellar tracking. So the normal, you have to get the normal quadriceps angle for the stretch and the tension going onto your patella to be in a proper direction, so your patella maintain a normal tracking. You definitely need to have a rigid and durable fixation of your total knee, so you don't have any early loosening, which may make your total knee unhappy. So again, to have a happy total knee, you need to restore the mechanical alignment. You need to preserve the joint line level. You need to balance your soft tissue. You need to restore the range of motion. And you need to have the knee ligaments balanced through this range of motion. You need to be careful about patellar tracking by maintaining a proper rotational alignment of the femoral component, restore the Q angle, and definitely to have a rigid and durable fixation of your total knee. Okay. So what shall I use? So a lot of implants in the market, many companies, and it's different in the UK, especially from trust to trust. Every trust is using an industry, a special industry, but you have to use the ODIP, okay? And ODIP is the Orthopaedic Data Evaluation Panel, and this has been generated after the NGR, and it's looking into the implant and how is this implant behaving, and it gives a rating of a number like 15A plus or 15A star. 15 is the number of years when this implant or this design is in the market. A means it has revision less than 5% in the last 10 years, and the star means this was supported by evidence, not only statistics. So ODIP, which again, Orthopaedic Data Evaluation Panel, it gives a rating for every implant in the market, for hips, for knees, for elbow, for shoulder, whatever replacement implant in the market, and it gives a number, a letter, and a star. Number means the number of years which this implant is in the market. The letter is saying this A, B, C according to the rate of revision of this implant within the last 10 years, and a star, which means this rate of revision is supported by an evidence, is not only statistics. The most common and the most successful knee was the BFC, which is a breastfeeding condylar, which is coming from Debwe Senses from Johnson & Johnson. And this maintained in the market for a very long time. It has a 15A plus, which is the highest ODIP rating in the market, because the revision rate for its CR implant was 3.18, and revision rate for the BS implant was 4.24. It's now replaced by Attune knee and is giving a good results, but it's still very young in the market. So ODIP rating for Attune knee is 7 years, not more than this, waiting for the new report. There is another common implant with the triethylene for Stryker, NextGen for Zimmer. This is the commonest implants in the market, J&J or Debwe, Stryker and Zimmer, which is Attune nowadays, replacing the BFC, triethylene, and NextGen. Good. How will I open my knee? So I decided to go for a total knee replacement. My patient have an advanced arthritis, exhausted all the non-operative measures. I evaluated my patient clinically, a history, examination, and investigation. I'm sure that my patient have an uncontrolled pain, which is affecting the normal day. I investigated my patient by proper X-rays, and my decision now is to go and do a total knee replacement. The commonest approach, according to the last report from the NGR, is the medial patellar approach. So you open just beside the patella, you divide your quadriceps tendon between medial 1/3 and lateral 2/3, and you go on the medial side of the patella until you reach the tibial tuberosity. The commonest approach, nicely expansile, very easy. The only problem is it gives some minimal numbness on the lateral side, because you will know in a minute that the neurovascular supply to the skin in front of the knee is coming from the medial side. So when you cut medial parapatellar, the patient have some lateral area of numbness or patch. Number 2, it may cause anterior knee pain. Number 3, it is a bit of problem for the patient when he is doing kneeling, like when he is praying if he's a Muslim. You can do a lateral parapatellar approach for a valgus knee because it gives you an easy access to release the structure laterally, but evidence didn't show any difference between medial and lateral parapatellar, and I have operated valgus knees from a medial parapatellar. You didn't need to go for a lateral parapatellar. It's definitely less expansile than the medial parapatellar. It gives you less exposure, though it gives you an easy access to the lateral side lateral release. You can go, as you can see from this picture, you can go mid-vastus through the vastus muscle, and the problem is this is leave a lot of scarring and maybe causing stiffness later on, and it keeps the patient in pain for a bit of time. Or to go subvastus, which is again a bit of anatomical approach, but is very, very limited. Others to go for a big expansile approaches, so you may go for quadriceps snipping. When you open the quadriceps itself, the problem is it's very expansile, but it weakens the quadriceps and carries the risk of muscle hernia and adhesions. You can do a VY turn down, or even you get osteotomy of the tibial tubercle, so get the anterior structure of the knee completely off, soft tissue knee completely off, and have a good access to your knee to do the total knee replacement. Again, 90-something% of the, don't have a clear figure, but 90-something% of the approach is done for total knees all over the world nowadays is a medial parapatellar approach. Okay, so nowadays, there is a lot of updates. Still, the AI didn't come into the picture, but we have the navigation, we have the robotic, we have the minimally invasive. Minimally invasive, to be honest, it didn't stay too long in the market, so it didn't show any benefit over the normal approach. So I don't think about the minimally invasive. Yes, you may aim for a shorter or a smaller approach, shorter incision, but minimally invasive, I don't think it adds any value to the total knee replacement. Navigation and robotic is very, very important, and this is again stress the point that a balanced knee, a balanced soft tissue knee is a very happy knee. And actually, when you start operating with navigation or with robotic, you will understand that all the navigation and robotic does, it do a kinematic knee, so it replicates the patient normal mechanical alignment. That's why it gives you a very good soft tissue balance and tension. That's why this knee is very happy. When you start to do robotic knee, my own notice or my own comment is the robotic knee, all what it does is to have the patient with a bit external rotated implant, femoral implant. The patient will have a very nice and good soft tissue balance and tension. That's why you will be surprised to see this patient the next morning moving full range of motion away from any pain. So actually, the robotic and navigation, all what they do is they allow you to replicate the kinematic alignment of the patient limb, and this allow a proper soft tissue tension, a proper component rotation, and this gives you, at the end of the day, a balanced soft tissue with a good range of motion, so a happy knee. Now we'll speak a bit, we'll touch a bit about the component design and biomechanics, and that's more of a mechanical point of view, but it definitely gives a big difference. So we'll speak about the insert, the femoral component, and the tibial component. When we speak about the insert, so we all know that the insert is ultra high molecular polyethylene. It has three or four shapes or designs. You play in the insert of or the polyethylene between 2 points. Make it more congruent or make it more mobile. If you make it more congruent, what you do, you get a more conformation of the articular surface, better range of motion. But on the other side, this makes more stress on the bone cement interface and cement the metal cement interface and cement bone interface. So the more you get your insert congruent, the more you have a conformation of the articular surface. This gives you a more freedom to move, but at the same time, it increases the stress over the bone cement interface and the cement implant interface. Other option is to have a flat geometry. So your insert is just flat. And at that time, there is no conformation of the joint because your femoral component is rounded, or even if it's rounded with a bit of flat surface, but the insert is completely flat. So there is no conformation of the articular surface. And this end by, you can do a proper roll back and flexion, but the problem again, there is a lot of stress on the insert itself. So the high risk of delamination, high risk of insert failure or poly failure. Again, you need to understand, ignore the designs, but you need to understand that the conformation of the insert or how much the insert is congruent with the femoral component gives you more range of motion, but at the same time, more stress on the interface. On the other side, if you get a flat insert, which is not congruent with the femoral component, this will end by It's still good movement because of the rollback, but at the same time, there is less stress on the interface, but higher stress on the insert because you do more of a point loading. So if you have a confirmation, this is moving easily, and at the same time, there is no point loading because the load is distributed over the whole surface. But this makes the movement, makes the two ball component move together. When the two components move together, this put an stress on the interface between the implant and cement and bone. But if you have a flat surface and the other surface is around moving on it, yes, there is a rollback. Flexion is still good, but there is no movement of the two surfaces together. There is no stress on the interface. But the other point, when this patient is standing, there is a point loading of the femoral component on the insert, and this point loading increase the risk of poly wear and increase the risk of failure. Insert mobility, the insert can be fixed in the tibial component. The insert can be mobile, and the insert can be in a form of rotating platform. If the insert is fixed, which is the commonest nowadays, there is a locking mechanism which holds the insert inside the tibial component. And the good thing of this, there is no risk of dislocation, there is less risk of delamination or back wear, but at the same time, this is increasing the point stresses and increasing the poly wear. The mobile bearing gives you a more dual surface articulation, something like the dual mobility in the hip. So the movement is in two planes between the insert and the femoral component and between the insert and the tibial component. So the mobile bearing insert gives you a two planes of movement between femoral component insert and between insert and tibial component. And this dual movement gives you a better range of motion theoretically, maximize the conformation because the insert is following the femoral component. But at the other side, it can be easily dislocating and it have a higher point flooding. Rotating platform is the idea. The idea is coming for if you to compensate for any misrotation you've done. If you do malrotation while you're inserting your components, the rotating platform will compensate for that. So the rotating insert platform can easily accommodate the malrotation of your tibial or femoral component. So it definitely reduces the soft tissue imbalance, definitely reduce the patellar tracking. Okay, so shall I put a mobile bearing, or fixed bearing or insert? Again, it's the idea as I told you. If you've put a fixed bearing, there is high contact stresses, there is no backside wear. You don't have any risk of dislocation of the insert or the plastic. On the other side, if you put a mobile insert, you have a risk of dislocation of the insert, you have a risk of higher backside wear, but at the same time, more conformation, better range of motion, and less contact stresses. Evidence come at the end of the day to say there is no significant difference in patient-reported outcomes between mobile and fixed bearing total knees at 2 years follow-up. So it's according to what you are using, what available in your shelf, and what's your learning curve helps you to do. Basically, you can use what works in your hand, but I can tell you from now, in the next NGR report, the fixed bearing is giving more consistent good results. That's why most of the people have moved from a mobile bearing to a fixed bearing. If we come to the femoral component, I need you just don't go into a lot of geometrical studies, but you need to understand that we have two types of femoral component, either a single radius or a multiple radius. Single radius, as you see on the right side, is just a ring. So it's uniform radius in all axes. But the multi-radius, as you see, is basically the manufacturing is trying to mimic the anatomy, trying to mimic the component, mimicking the femoral condyles or the distal femur. So this one is a uniform radius, so single radius in all planes. So it is more of a rounded component, which is not fitting anatomically on the femur, but on the other side, it has some relevant values I will tell you about now. On the other side, the multi-radius is mimicking the anatomy, but as you can see, it's not fully rounded. So what's the difference? With the single radius, as you can see, the single radius component is making it round. So when you have this total knee moving from flexion to extension, there is a uniform stress over the lateral collateral ligament and medial collateral ligament. So your collateral ligaments are isometric because this is a rounded component. It moves. It has the same distance at the joint line at all time. So it is more of a rounded, like you're moving a ball. So there is an isometric stresses coming over the collateral ligaments with maintained tension. So there is no mid-flexion instability. There is no anterior knee pain. On the other side, there is good conformation. So with the insert or the plastics, so it's again giving you a good range of motion and reducing the joint stresses. The multi-radius is a G-shaped in the sagittal plane, as you can see in this picture. It's more of an anatomical implant. It's more mimicking the anatomical distal femur, and some of them are variable radius, which is going with the component medial and laterally. So the radius in the medial side is bigger than the radius in the lateral side, and both of them has a multi-radius. So in the multi-radius, what you are doing, you're getting a more larger distal radius, mimicking the normal anatomy of the distal femur, and this is making a more curved posterior part. Though this is giving you a better femoral rollback, which is giving you a more or better flexion range, but it doesn't give the same uniform strain over the collateral over time. So when the knee moves from flexion to extension with the component is a multi-radius, so sometimes when the radius is very large, the ligaments is under tension. When the radius is very small, the ligaments are lax. That's why the ligaments are not uniformly tensioned through the whole range of motion. That's why the patient with multi-radius design have a mid-segmental or mid-range instability or mid-flexion instability, and this could be one of the causes of anterior knee pain, could be one of the causes of early failure. So single radius is just a ring, have same radius all over the contour. Multi-radius has a different radiuses according to the place, so it mimicking the normal anatomy of the distal femur. Single radius, the good thing about it is it maintains a normal isometric stress over the ligaments in all range of motion. Multi-radius not, because with large radius, there is a tension over the ligaments, collateral ligaments. With a small radius, there is a laxity over the collateral ligaments. So the collateral ligaments are not under uniform stresses through the whole course of movement or range of motion. That's why you may have a mid-flexion or mid-range instability. The single radius, the good thing about it is it gets a conforming insert, so good range of motion. The multi-radius on the other side have a more benefit with the roll backing because of the shape of the distal femur. It mimics the shape of the distal femur, so the femoral rollback is better, so the range of motion of flexion is better. Evidence, what does the evidence say? The evidence says no significant difference in survivorship between both of them. The medial pivoting design, or as I told you, the variable radius, it is have a different radius medially than laterally. So it's not only multi-radius in the sagittal plane, but it's multi-radius in the sagittal plane and axial plane. So the radius is different from medial to lateral, trying to get a more anatomical mimicking structure to the distal femur. So you have dual radius, dual multi-radius design, aiming to maintain the anatomical shape of the distal femur. So we spoke about restoring the anatomical and mechanical axis. This is the anatomical and mechanical axis where I'm just stressing on it. Sorry. So as we all know, the mechanical axis comes from center of the hip to center of the ankle. And normally it should go through the center of the knee. Anatomical axis is the mid-axial in the femur and mid-axial in the tibia. More or less, the anatomical and mechanical axis in the tibia are the same. In the femur, the anatomical axis is about 7 to 9 degrees lateral or valgus to the mechanical axis, and this is what from where come the Q angle or the quadriceps angle. So we aiming in our total knee replacement is to restore the mechanical axis to, at the end of the day, after I bought my knee, I need the center of rotation of the hip to be in the same line with the center of rotation of the ankle, passing through the center of rotation of the knee. We use the anatomical axis because the mechanical axis is different from patient to patient, but we keep in consideration that we need to put our implant in valgus position to maintain, because our cut is mainly about get a cut perpendicular on the mechanical axis, not the anatomical axis. A lot of debate about kinetic, kinematic, and mechanical knee alignment. We don't go in this debate at the moment, but all what you need to know, what is anatomical, what's mechanical, what the difference between anatomical and mechanical in femur and tibia. And to understand that we're caring about the mechanical axis, though we are using an anatomical reference, we keep in mind that we need to put this anatomical reference in a valgus cut to make it perpendicular over the mechanical axis to end by a total knee replacement, maintaining the mechanical axis of the limb. So the mechanical axis passes from the center of rotation of the femur to center of rotation of the hip, center of rotation of the hip to center of rotation of the ankle through the center rotation of the knee. The point is, in varus knee, we understand that there will be a medial mechanical axis deviation. So the mechanical axis will be going in, and in a valgus knee, the mechanical axis will be going out. And it's our rule in the total knee replacement when we have a weight-bearing standing full limb X-ray is to understand where is the problem in the mechanical axis and try to correct this in our cut to get a total knee replacement under the normal mechanical axis of the knee, of the limb. So how I prepare my femur? So you need to understand, once I open my knee, I clear the Hoffa pad. My knee is clear in front of me. I reflect the patella out. So the femur is in front of me. Now I want to do a referencing for the femur. To do a referencing for the femur, we go through the center of the femur. We agreed in the all lectures in the first lecture that going through the femur, you go just posterior to the origin of the BCL. So you are sure you are in the center of the medullary canal of the femur. So you go with your referencing device or jig. So this is an anatomical reference. That's why we put it in about 7 to 9 degrees of valgus, and we cut according to what we need to cut from the distal femur. So the valgus cut angle is actually the angle correcting the relation between the anatomical and mechanical axis. Because we're using an anatomical reference, we put our stem is inside, or our jig inside the medullary canal. This is anatomical, but we need our cut to be perpendicular on the mechanical. That's why we put a valgus cut angle from 5 to 7 degrees. I put my reference inside. I put 5 to 7 degrees if I'm doing a varus knee. This is a bit different if I'm doing a valgus knee, which has an already hypoplastic lateral femoral condyle. So most of our talk today will be about a standard varus knee. Then I will tell you in the middle what's the difference in valgus. But all this is on a standard varus knee. So I put anatomical consideration. I put my jig inside the medullary canal. I have an anatomical reference. I put a valgus cut angle 5 to 7 degrees to make my cut perpendicular on the mechanical, not the anatomical. Then once I do that, I make the distal cut. Making the distal cut, you need to understand that you're preparing this according to what you need to maintain your joint line. So according to what you're doing, is it a big knee? Is a small knee? Is the patient has a fixed flexion deformity? If patient doesn't have a fixed flexion deformity, this depends how much you will cut from the femur. Once you cut your distal femur, the second stage will be how to size your femur. So how to know the anteroposterior size of your distal femur. And you have two options, either to do this depending on the anterior reference, either to use the anterior femur as your reference or the posterior femur as your reference. The commonest, if you have a standard varus knee, is to use a posterior reference to reference your cut on the posterior condylar axis. So difference between anterior referencing and posterior referencing, as you can see, in the anterior referencing, you start from the anterior side and then you size your femur, and you do that in two conditions. If you have any problem in the back, especially if the patient has a fixed flexion deformity, big osteophyte, or if the patient have a valgus knee, because in valgus knee, the problem is you have a hypoplastic lateral femoral condyle, so you cannot use a posterior referencing. You have to depend on anterior referencing to do. Posterior referencing, which is commonly used in the standard varus knee, and all of us use it even sometimes on the valgus if it's not a bad valgus knee. So you reference your point on the posterior condylar axis and then measure the size of the femur. What's the problem with the anterior referencing and what's the problem with the posterior referencing? The problem with the anterior referencing, that if you go with the anterior referencing, you go magically with the anterior referencing and you do a big cut, so you will cut a lot from the posterior femur, and you will end by a loose flexion gap. On the other side, in the posterior referencing, if you cut more from that, you use the posterior condyle as a reference. If you cut more from the anterior referencing, you'll end by notching the femur. So if you don't do any of them properly, you will end by a problem. So you can use whatever you feel comfortable with. You can use anterior referencing, you can use posterior referencing, but you need to do it properly. Anterior referencing, you depend on the anterior femur and you measure to the back. If you go crazy, you will cut more from the back and you will end by a loose flexion gap. if you do a posterior referencing and you don't do it properly and you go crazy, you will cut a lot from the anterior femur. You will end by a notching in the anterior femur. Okay, so I've cut based on a posterior referencing or an anterior referencing. What if I come between sizes? So it is started from 4, 5, 6, 7, 8. So what if I come between sizes? Always use the down size, because using the down size, you cut less from the bone. So you still have an option to correct. So if I come between 4 and 5, I will cut on 4. When I cut on 4, I cut less from the bone. Then when I do my trial, if I feel no, it is it's a bit tight, I need to cut more from the bone, I can go to 5. But if you go from the start to 5, you don't have an option to both bone back. So if you come between two sizes, always down size. Okay, so I cut my femur, my distal femur is in front of me, cut it now. And now I want to put the jack to cut the posterior femur and the anterior femur. Putting your jack, you need to understand the normal rotation of your distal femur. So actually, if you're using a posterior reference, this posterior referencing, or the posterior condylar axis or posterior condylar line, is actually internally rotated over the epicondylar axis, which is the actual axis of the femur, by about 3 degrees. So if this is called the white side line. The white side line is coming from the apex of the trochlea, perpendicular on the transepicondylar axis. This is the epicondyle, medial epicondyle, lateral epicondyle. The transepicondylar axis is here. The white side line is perpendicular on it. So this is the actual reference of rotation of your distal component, of the distal femoral component. You cannot see this. You can draw it, but you cannot see it. What you can see is the posterior condylar line. If you depend on the posterior condylar line, you will cut the femur with about 3-degree internal rotation. As we agreed in the previous slide, if you cut the femur in internal rotation, you will lose tension of the, you will not have a rectangular gap. You will lose tension of the ligaments, and you will do a mal-tracking of the patella. So what you do, you just put reference in the posterior epicondylar axis and make 3 degrees in external rotation, so you can maintain your component in an external rotation. If you have a valgus knee, you have to be careful. You have to draw these lines and follow them, because this reference is gone, because you have a hypoplastic lateral femoral condyle, so you don't have an option to use a posterior referencing. But if you're doing sizing on a standard varus knee, you have a normal femoral condyles, you do this referencing posteriorly with the 3 to 5 degrees of external rotation, just to mimic or to follow the epicondylar axis, which is the actual axis of rotation of the femur. How this external rotation of the femur makes difference, I can tell you from my experience, it makes a huge difference. This is how you get a good range of motion, a balancing gaps, either flexion and extension, and your patient will have a much better results. So mistaken rotation of the femoral alignment, femoral component alignment, is a major mistake, ended by an unhappy total knee replacement. So I sized my femur, I cut my femur, and now I'm going to cut my femur from front and back. So and then the chamfers. So you cut femur from the front, you need to see at the end this grand piano sign. You need to be, because you know there is a difference between the medial and lateral condyle of the femur. So you need to see difference in cutting between the medial and lateral. Be careful about notching, because if you notch the femur, if you cut more from the cortex, this will be a stress riser point. So it will be a point for the failure to start from. So be very careful when you're cutting the anterior femur. And as we agreed, if the sizes is between size, go for the down size to cut less from the anterior femur. So get away from notching the femur, because if you notch the femur, risk of fracture will be very high, because this area will be a stress riser area. Now we're done with the femur. Cut front, cut back, cut chamfers. Your femur is now ready. You're going to do the tibia. In the tibia, we reference either anatomical or mechanical. So we either go intramedullary, we stick a jig inside the medulla and measure on it, we always use this in the revision cases. For the primary cases, we always do an extramedullary reference. So put a reference from outside, put your jig parallel to the intermalleolar axis, so you're sure that your jig is standing on center of rotation of the ankle, and go up to the center of rotation of the knee, and be sure that this is following the shin in the front plane and in the sagittal plane. And that this is very important, because when you're operating on the total knee at the start, you're looking from the front, and you're trying to be sure that this is extramedullary jig is following the shin of the tibia anteriorly. No. Be careful if this jig is not parallel to the shin in the anterior posterior plane and in the sagittal plane. It may be going down or up, and this will be changing the slope. So to do an extramedullary reference, you need to be sure that jig is holding on the intermallear space. You are on the center of rotation of the ankle. Your jig is going parallel to your shin of the tibia in the anteroposterior and lateral. So parallel to the shin of the tibia and the anteroposterior, and from the lateral side, there is a uniform space or parallelism between the jig and the shin of the tibia. Controlling the rotation, where shall I put the rotation of my tibial cut? You need to put it in a point between the medial third and lateral 2/3 of the tibial tubercle, because this is where your tibia should be to allow your patellar tracking to be uniform. So the reference for the rotation of the tibial component is between the medial third and lateral 2/3 of the tibial T-prosty. And this is allow you to be in a point of external rotation, which means an internal rotation of the patella, so normal patellar tracking. Remember, we speak about the tibial cut and the tibial component. The more you externally rotate the tibia, the patellar tendon is in place. So the more you externally rotate your tibia, you are relatively internally rotating your patella. Remember that. So external rotation of the femur, external rotation of the tibial component, allow relative internal rotation of the patella, so patella has a proper tracking. Because if you look at it, if I externally rotate the tibia, this means I'm getting the whole patellar tendon out. No, you're cutting above the patellar tendon. So the more you externally rotate the tibial component, the more you externally rotate the femoral component, the relatively you put the patella more in, so put the patella at better tracking and less risk of dislocation laterally. I hope this is clear to you. Varus valgus, so normally the normal tibia has about 5 to 7 degrees in the back sloping, and it has about 3 degrees varus angle. So the normal tibia is the normal tibial cut, the normal tibial plateau is 3 degrees in varus over the mechanical axis. We ignore that because it doesn't make a big difference. So we cut perpendicular on the extramedullary axis or the jig we're using. So you need, once you put your jig, be sure it is on the center of rotation of the ankle. Be sure it is following the shin in the anteroposterior and lateral view in a uniform place. Then ensure that the rotation of your jig is at the junction between medial third and lateral 2/3 of the tibial T-prosty. Then choose how much do you want to cut. Ignore the 3 degrees varus position, and then from your jig, choose the slope as you want, depending on what you're using. So if you're using a CR knee, you put the slope between 5 to 7 degrees. If you're using a PS knee, you can put the slope between 0 to 3 degrees. Why? Because the main function of the slope is to help the BCL. So if you have a slope, it's easy for your knee to posteriorly sublux it. And what stops that is the BCL. So if you're doing a CR knee, means you are maintaining the BCL, you will not cut the BCL. So you don't care about the slope, you put the knee in a normal slope, which allow better flexion. But if you're doing a BS, which is you will be sacrificing the BS or the BCL, means you don't have anything to stop the posterior subluxation of the tibia. So you have to make a higher slope to make the slope, a lower slope. So make the slope about 0 to 3 degrees to stop posterior translation of the tibia. Again, center of rotation of the ankle, my jig is parallel to the shin. My jig in the anteroposterior and lateral, there is a parallelism between the shin of the tibia and the lateral side and the jig. My rotation is based on one third to 2/3 from the tibial T-prosty, and then my cut level of the cut, I decide according to how much I need to take from the tibia. How much? Some people take 2 mm from the worn side, or 7 to 9 mm from the normal side. It's according to what you do. The most important about the slope, if I'm doing a CR knee, so means I'm maintaining my BCL, so I don't worry about posterior subluxation of the tibia, because this is the function which the BCL is doing. So I try to mimic the normal slope, which will be 5 to 7 degrees, because this allows a proper femoral rollback, a proper knee flexion. But if I'm doing a BS knee, and we know in a minute why I do a BS, why I do a CR. If I'm doing a BS knee, means I'm sacrificing the BCL. There is no BCL, so nothing to stop the posterior translation of my tibia. So I have to maintain a low slope about 0 to 3 degrees. So CR knee, I cut the slope at 5 to 7 degrees. BS knee, I cut the slope at 0 to 3 degrees, because I need the less slope to do the action of the sacrificed BCL. Rotation, we agreed. Tibial component has many different designs. So it could be cemented, could be cementless, could have a stem inside, could have a big inside. It could be a monoblock, it could be modular. Monoblock means the tibia and the insert is one piece. And the problem with that is you don't have a lot of accessibility. You cannot remove any extra cement. You cannot do anything. You cannot play with the size of the insert. But if you have modular, which we all use nowadays, you have a tibial component alone, insert alone, and you can play with the insert. You can go around, you can take any cement out, and you can choose your insert. If you make a mistake, like you cut more from the femur, cut more from the tibia, you have your friction gap tight or loose, you can play with the insert side, which you cannot do with monoblock, but you can do with modular. There is an all poly knee, which is the whole component, tibial component is poly, but it's not common nowadays. So I'm preparing my tibia. So what shall I do different if I have a valgus knee? Remember, if you have a valgus knee, you cannot depend on the lateral femoral condyle as a reference because you have a hypoplastic lateral femoral condyle in valgus knee. So you need to use anterior referencing rather than posterior referencing. You need to use medial referencing rather than lateral referencing. So don't depend on the lateral side at all, neither anteroposterior or mediolateral, because the lateral femoral condyle is hypoplastic. So all the measurements you will take from the lateral femoral condyle will be mistaken, and you will end by an improper position of the component and a problem with the balance of your soft tissue. Patellar tracking is very, very important, and this is one of the most common complications of the tooth and knee, and one of the most common reasons why a tooth and knee go back to theater. That patellar mal tracking. You have to be 100% sure that your patella is properly tracking on table before you get patient off table. If you get patient off table, you're done. There is nothing to do with it. So how to avoid mal tracking? As we agreed, proper position of your component. Your component has to be medialized, mediolateral, and rotated. Avoid as much as you can more medialization and avoid internal rotation. So your component has to be medialized, laterally, externally rotated. If you do more medialization or more internal rotation, you will lose the tracking. Q angle, you have to maintain a Q angle, so you have to do a valgus cut. If you go crazy with a valgus cut and the Q angle is very high, especially above 15 to 20, will take the patella out, so the stresses on getting the patella out will be higher than in, so you will end by dislocated patella and mal tracking. Number 3, when you put your button, you have to medialize your button. Remember, this is the patella. When you medialize the button, you're actually lateralizing the patella. When you're lateralizing the button, you're medializing the patella. And all what you need is the button to be medialized, to be tracking nicely inside the groove. You don't care about the patella. So again, number 1, you have to put a proper cut. So the your Q angle is between 7 to 9 degrees. If you go crazy in the Q angle, you will put more stresses on dislocating the patella laterally and mal tracking. You have to position your component properly. So your component should be minimally medialized and externally rotated. Don't go badly medializing it or internally rotating it, because internally rotating the femoral component or the tibial component means you relatively lateralizing the patella and doing a mal tracking and patellar dislocation. Your patellar button is the other way around. So you need the patella to be lateralized. So you medialize the button means you lateralize the patella. So minimal medialization and external rotation of the component femoral and the tibial, medialization of the patellar button, so you're sure that you're maintaining a proper tracking of the patellofemoral joint and you don't have any patellar femoral mal tracking or dislocation. You have to try the patellar tracking at the full range while your patient on table, because any proper with the tracking, you cannot get your patient off table without a proper tracking. Otherwise, you cannot correct this post-operatively, means you will get your patient again to theater. How mal tracking? How you catch the mal tracking? So you catch the mal tracking by examination. You do full range of motion and you see how the patella will go through the trochlear groove. What if I have a mal tracking? Number 1, if you're doing the knee under tourniquet, you have firstly to get the tourniquet off, because the tourniquet is tethering the quadriceps muscle. So it could be one of the causes why the mal tracking happened. So your component is nicely positioned. Your patellar button is nicely positioned, but it's still mal tracking. Mal tracking, why? Because the tourniquet is just tethering the quadriceps muscle and it's not normally moving. If I got my tourniquet off, mal tracking is still there. I have to think about my component position. So I still trying. So I haven't cemented anything. I have to start looking into my component if I medialized it too much or I internally rotated, so I have to correct that. If no option, and still mal tracking, I can do a lateral release. Normally, we release the lateral patellofemoral without mal tracking because it doesn't do any job at that moment. So we remove the lateral patellofemoral ligament. If this is not enough, even we can do more lateral release of the patella to be sure that the medial structures are more robust and more strong. So there is no lateral mal tracking. So remove your tourniquet. If not, get your position and rotation of component properly. If not, do a lateral release of the patella until you be sure that your tracking is perfect. There is no option to get patient off table without a proper patellar tracking. How we catch it post-operatively? Patient will come with anterior knee pain, clicking, unstable patella, in pain. He's not happy. So how can we catch that? We do a CT scan, which will show us the malpositioning of the patella and give us an idea where is the problem. The total knee designs, what using nowadays is the commonest is unconstrained, semi-constrained, or constrained. And the constrained means how much it is. It has an inherent stability of the implant. The more the constrained, the more the stability, the inherent stability of the implant, and we use that when the knee itself is not stable. The unconstrained is the CR knee, which is the cruciate retaining knee, means you don't get the BCL off. So you're maintaining the normal ligaments of the knee. So you're maintaining the normal proprioception of the knee because BCL play an very important role in proprioception. And you're maintaining an important ligament to stop posterior translation. And that's why you can mimic the normal tibial slope and give the patient a good range of motion. This is the cruciate retaining implant, which you see here on the left side. As you can see, it just you're doing a surface replacement. You replace the femur, replace the tibia, put a tibial insert in between them, and that's it. You maintain your BCL. ACL is gone, but you maintain your BCL, your ligamental structure of the knee normal, your biomechanics of the knee normal, your proprioception of the knee normal, and you do a normal slope, which gives the patient a normal flexion, femoral rollback and normal flexion, because you don't worry about posterior translation of the tibia since the BCL is functioning. The second option is BS, which is posterior stabilized, and this is depend on a cam and a cam and the hole here should just hold the mechanism in place. So a cam and a slot. So the slot in the femoral component, cam coming from the insert, and this is stopping the anteroposterior movement of the tibia. So basically, the cam and sorry. I'm sorry. Okay. So the cam and the box is doing the job of doing the job of the BCL. So maintaining the anteroposterior stability of the knee. And you do BS for certain reason. We'll go through it in a moment. When you are obligated to release the posterior structure, get the BCL off. And what's the problem with getting the BCL off? So you lose a constraint against the posterior translation of the tibia. You lose the proprioception. You lose the femoral part of the femoral rollback. So your knee is not mechanically sound as before because you get an important ligament of the knee off. So the cam and the post, or the cam and the box, is doing the job of the BCL. So the cam and the post in the back, as you can see, is just stopping the anteroposterior movement. They don't do any role in the varus valgus. So if the MCL is gone, if the LCL is gone, if you worry about the stability of varus valgus, BS is not the need to use. You need to use something more constrained. BS has the same indication as CR. All the difference is you have to lose the PCL. You go from CR to BS. But other than this, no. So the BS is different than the CR, that it helps with the anteroposterior stability, not the varus valgus stability. So the BS is form of very minimally constrained implant, but it is still between unconstrained to minimally constrained. When we go with the constraint, we have many options, starting from the condylar knee. So the condylar knee is having a cam, but this cam this time is a bigger cam and it's the middle. So it's giving some anteroposterior and varus valgus stability, but still the knee is moving freely and ending by a rotating hinge. When you have a hinge between the femoral and tibial component, which is controlling the whole knee movement on behalf of a lot of problems. I will show it to you in a minute. So there is no ideal answer. Anytime you play with the constraint, you affect the interface. Anytime you keep the constraint, you affect the stability. And I'll explain this to you in a minute perfectly. But you need to understand we have total knee designs. The total knee designs play from a cruciate retaining to a posterior stabilizing to a constrained, and constrained could be constrained non-hinged, could be constrained hinged. So CR, as I told you, everything is maintained. BCL is in place. Normal slope, normal flexion, normal femoral rollback. There is nothing, normal proprioception. BS is knee is stable. All what I've done is I got the BCL off, and I use the cam and box or cam and booster just to maintain the anteroposterior stability. But CCK, I'm using a cam in the middle, which is maintaining the anteroposterior and the varus valgus stability. So it's a constrained but not hinged. And the last thing is a rotating hinge. As we agreed, CR, femoral rollback is maintained, proper flexion because the tibial slope is maintained, the BCL is functioning, so I didn't miss anything from the normal mechanics. But it's because to maintain the femoral rollback, I have to have a multi-radius femur, so it's a bit low conformity. So it may be some round on a flat, so maybe some joint loading. But I preserve the BCL, I maintain the relation between tibia and femur, I maintain the proprioception. It gives me an option to give a normal slope or cut a normal slope, which will allow me to have a normal femoral rollback and a normal flexion range of motion. Advantage, femoral rollback, improve knee flexion, preserve some proprioception by the BCL, anteroposterior stability because BCL is still there, bone conserving, I don't cut a lot from the bone. Disadvantage is, as I told you, a bit technically difficult because I need to have a normal proper ligaments. I cannot do a CR in a patient with lost BCL, patient with a lot of osteophyte in the back, patient with a rheumatoid, which is the soft tissues are very bad and the ligaments are not functioning well. So it's a bit technically difficult. I have to have a balanced knee, and I don't have any. If the BCL is contracted, if any contraction around the knee is not easy to open, knee is very tight, BCL will be really difficult. CR will be a bit difficult technically. If BCL contraction, limiting the balance, BCL can stretch with time, so give a bit of instability, even a micro instability. Less constraint, less conformation because it's a flat on around. So a bit of point loading and increase wear. So this is the advantage, disadvantage of CR. PS, as you can see on the right side, we agreed there is a Boston cam, and the Boston cam is maintaining the anteroposterior stability, doing the job of the BCL. So as a base, as I told you, we get the BCL off for a lot of reasons. Commonest, we use the BCL for the reasons I'll tell you now, but the commonest is if the patient has a fixed flexion deformity, we have to do a lot of posterior structure release, and we end by a loose flexion gap. So there is an risk of anteroposterior instability. So BS is mandatory. Indication for BS, as we agreed, inflammatory arthritis means I'm at a risk of losing my BCL, and even if the BCL is there, will be very slim, will be easily stretchable, easily ruptured. So I cannot trust the BCL to do the job. So I have to go from CR to a BS in a rheumatoid knee. If I have patellectomy, so patellectomy, there is weak extensor, there is nothing anterior, no anterior strut, no anterior support. So I need something to do the job of the patella and the quadriceps. So I need a BS to control the anteroposterior stability. As I told you, if the patient have a big fixed flexion deformity, means to get this knee to full extension, I need to release a lot posteriorly. And if I get a lot posteriorly, one main structure for posterior release will be PCL. And once I lose my BCL, I need a PS knee. Definitely, if patient have a BS injury or fixed varus and valgus deformity, which is aggressive, needs a lot of release. What's the problem with BCL? If BCL is nice, why not to do every knee as a PS? The BS problem is you can have a femoral cam jump. So easily the femoral cam can jump out from the cam come out of from the box. You need to get a lot of bone. You're not bone conserving. You cut a lot of bone from the femur to make a space for the cam and box. You can have an extra bully. You have an extra polyethylene, which may be at risk of wear and problems. You can have a patella clunk because every time the cam moved over the box, it gives you what's felt like a clunk. And definitely because it's a bit of constraint than the CR, it goes on behalf of the interface stress. So to understand, every time you constrain the knee, this means the two components move together or very related to each other. This means the increased stress is over the implant cement and the cement bone interface. And that's the balance. You have to balance the stability of your total knee and the interface stress. The more you get a constrained knee, the more stress in the interface, and the other way around. That's why you need to be very balanced. There is no ideal answer. Constrained knee is more safe from instability, but on behalf of that, is more prone to easy loosening because there is a lot of stress on the interface between the implant cement and cement bone. So BS is a form of a bit of semi-constrained knee. So there is more stress over the interface between the cement and the implant and cement and bone. So risk of loosening is there. So shall I use a CR or a BS? A good question, which has been answered many times in many systematic reviews and meta-analysis, and both came to say there is no major difference, though there was a finding in 2018 finding that the BS has a better range of motion, which is very strange. Though at the end of the day, the result, the satisfaction from the knee, the problems are the same between CR and PS. Next level is to have a constrained condylar knee or CCK from Nexigen from Zimmer. And as I told you, this has, as you can see, a big cam in the middle. And because it have a big cam in the middle, it's control anteroposterior and control varus valgus. So if I have minimal injury to MCL or LCL, they are not functioning well, I'm worried about movement varovalgus or anteroposterior, I bought a constrained knee. The problem, as we agreed, the more the constrained knee, the more stress on the interface between the implant and cement and bone. That's why we have to use a stem. We cannot use big or small bigs anymore. We have to use a big stem because we need a proper holding in the femur and tibia, not to allow an early loosening. That's why it's very important to have a stem in a constrained knee. Going more constrained, so if I have a global instability, I don't have anything working from the ligaments anymore, so I have to go for a rotating hinge. When I put a hinge in the middle, I'm pretty sure I will not allow my knee to move anteriorly, posteriorly, varus or valgus, mediolateral translation. There is no movement because there is a jam in the middle, stopped at the hinge. I use this in global instability, polio, massive bone loss, knee resection, definitely in revision knees. So I have to use a hinge. Again, the problem will be more forced transmission across the interface, early loosening, and higher problems. Soft tissue balance is the most important. And when you go to the soft tissue balance, you need to understand that without soft tissue balance, you have a failure of your total knee. Total knee is a soft balancing procedure. Total knee is a soft balancing procedure. How to get a proper soft balance if you are not using navigation or robotics? So by hand, you have two ways to do your total knee in regards to the soft tissue balance. Number one is the measure resection. So you go as a standard, and the problem here is not all your patients standard. So you have a standard technique. You cut at your valgus cut at 7 degrees. You cut from the femur at 10 mm. You cut from the tibia at 3 degrees. Your rotation is that. Your rotation is that. You cut from the worn side in the tibia at 2 mm or 3 mm. So you do a standard measure resection based on what you've seen pre-op in the X-rays. But as I told you, the problem you're using a standard method in an non-standard patient. The other way, which is the more physiological, more balanced, is to use a gap balance. So you depend on the soft tissue balance to guide you how to cut your bone. So the difference between measure resection and gap balance, with measure resection, you cut the bone, and the cutting the bone will guide the balance of the ligament. But in the gap balance, you firstly balance the soft tissue and the ligaments, and this will guide you where to cut your bone. And the gap balance sizer is the one you see on the middle side, which, as you can see, is sizing the femur based on how much he get, or how much he needs to do to get a balanced flexion gap. This is how he gives you the size of the femur. So he doesn't size the femur based on actual size, but size the femur based on a balancing gap. So it aims mainly to balance the gap and soft tissue, and this is guides where he should or she should cut the bone. So what balance do you need? So soft tissue balance you need is soft tissue balance in the sagittal plane. So you need in the sagittal plane to have equal gaps in flexion and extension. And as you can see, the equal gaps needs to be rectangular, uniform, so you can have a proper gapping in the both flexion and extension. And you need to be sure that you're doing proper release medial, proper release lateral, proper release anterior, proper release posterior. So based on actual situation under soft tissue tension, your gaps in flexion and extension are balanced. What if I have a tight flexion, a tight extension, a loose flexion, a loose extension? We'll go to this in a minute in a very nice table, which you need to remember by heart. So if I want to do a soft tissue balance, and my tighter side is the lateral side, release will be starting by removing the osteophytes, then releasing the iliotibial band, then releasing the lateral capsule. Then if my knee is tight, the lateral tightness is in extension, so the iliotibial band either Z-blasty or complete release. If the tight is in flexion, I have to release the popliteus or part of the LCL. If in both, LCL has to go. Posterior structure, if the tightness is posterior, I release the posterior osteophyte, then the posterior capsule, then I go to the BCL, remove the BCL, and at late stage I can go with a Cooper or go with a Bristol and release the gastrocnemius. On the medial side, which we have to do with every varus knee, because on the varus knee, the tighter side is the medial side, we remove the osteophyte, MCL, medial capsule, and then if no option, BCL, and at very late stage, I can do a Z-lengthening in or plication in the superficial MCL. You cannot take the MCL off, otherwise your knee will be unstable and you will need a rotating hinge. So what if my gap is not balanced? So I've done a medial release or lateral release or posterior release. I tried to prepare proper bone cutting. I got my bone cut on a major resection, and my gaps are not balanced. Definitely, if you're doing a gap balance technique, there is no option for that, because you balance the soft tissue firstly, and this guide you where to cut your bone. The problem of gap balance comes with the major resection. If you do a major resection, you're cutting the bone as a standard, you end by improper gap balancing or improper uniform gaps. What shall you do? So if you have your gap tight in extension but and tight in flexion, means your problem is in the tibia. So the femur has a distal and posterior component. Tibia has one component, it's only one cut. So the posterior component of the femur affects the flexion gap, the distal component of the femur affects the extension gap. What if you have tight gap in flexion and extension? You have to cut the tibia. You cut more from the tibia or you make smaller inserts. What if your gap is tight in extension but normal in flexion? If tight in extension and normal in flexion, all what you need is either to cut more from the distal femur to give a more flexion, or to release the posterior capsule or BCL. What if your gap is tight in extension and loose in flexion? So the problem here, if tight in extension, loose in flexion, means your problem is in the distal femur. So either to put a femoral augment to increase that, or to upsize the femoral component to give to tighten the flexion gap a bit. You go through this table is in Orthopolis, is very important. You have to understand it well and remember it by heart. It comes in every exam, in every question, in every trauma meeting, in everything. What to do if tighten extension, if tighten flexion, tighten extension and flexion, tighten extension, normal flexion, tighten flexion, normal extension, tighten extension, loosen flexion, tighten flexion, loosen extension. Remember this very well. It's very easy to remember. If you imagine where you cut in the femur distally and posteriorly and the tibia, what is the structures which working on the tightness, it'll be very easy to remember. Last one is what I do with my patella. Shall I resurface every patella, or shall I resurface certain patellas, or shall I not resurface any patella? Answer is very easy. We resurface the patella now very regularly, because statistically and NGR reports has found that the commonest cause to get a total knee replacement back to the theater is patellar maltracking or anterior knee pain, which needs a patellar resurfacing. That's why nowadays everyone is resurfacing the patella. What's the benefit from resurfacing the patella? So you play with the patellar tracking, you put your patellar button wherever you want, so you can maintain a tracking or correct a maltracking. You reduce the height, so there is no tightness and extension, there is no over tightness of the component, there is less anterior knee pain. And as I told you, the main reason or the most important is you will not get this patient back to theater to resurface the patella, because they found that the commonest cause of revision of total knee replacement is to get the patient back to resurface the patella. That's why nowadays we're resurfacing the patella from the start. On the other side, the resurfacing of the patella is not always benign. because you can easily cut more than enough and end by fracture of the patella. You can easily dissect a lot around the patella and end by a vascular necrosis. Or the other side, you cut less from the patella, and this will end by overstuffing, loss of extension, and anterior knee pain. So what shall I do to get my patella resurfacing proper? Number one, when I'm cutting, I have to measure the patella. It's commonly to be about 25 to 30 mm. So I need to keep at least 13 mm. So I cut between 10 to 12, not more, not less. Then I be careful about the advance of the design of my total knee. Nowadays, the total knee advances is giving a more deep trochlear groove, which is more friendly with patellar tracking. But I need to remember that I have to medialize my button to get the patella lateralized and get a normal patellar tracking. What the clinical outcome, if we speak about patellar resurfacing, as you can see, there is no major difference. But all what we spotted is in non-resurfaced patella, these total knees always go to the revision because of that, because of anterior knee pain and need to resurface the patella. That's why nowadays we say resurfacing every patella. What if I have a pre-prosthetic patellar fracture? We deal it as a normal patellar fracture, as a normal extensor mechanism rupture. Type 1 is if you have a stable extensor mechanism, so you don't care about the fracture, treatment will be non-operative. Just put this patient a cylindrical cast for 2 to 4 weeks, then put this patient, start to put this patient in range of motion brace and improve it time by time, depending on the healing. Number 2, if the implant is stable but the extensor mechanism is gone. Number 3 is the extensor mechanism is gone and the implant is loose, but still there is some bone stock. We say it's 3A. 3B means loose implant, rupture extensor mechanism, and there is no bone stock. Last slide is about patellofemoral arthroplasty, and as patellofemoral arthroplasty, as we understand, it's not common nowadays. It's very rare, but you can do that in a young patient who have an isolated patellofemoral arthritis. It's more of a resurfacing arthroplasty. You will not see it very commonly because it's very rare nowadays to do it. There's certain centers which does that, but the normal daily practice doesn't include any patellofemoral arthroplasty. This is not because it's not there, but indication is not that high. And commonly, this patient never come with a unicompartmental arthritis. This always many compartments. What the contraindication to do as an isolated patellofemoral arthroplasty? If you have definitely instability, as any joint, if is neuropathic, definitely. If active infection, definitely. If there is no other, if there is other compartment arthritis, there is no point to do an isolated compartment replacement while you have medial or lateral compartment arthritis, because you put the patient at risk of having another operation to replace the other compartment very soon. If patient has a high demand, because if patient has a high demand with patellofemoral arthroplasty, your patellofemoral arthroplasty will fail. The reported results is poorer than the total knee replacement, so that's why it's not that common nowadays. So all the results is supporting to have a total or a unicompartmental knee rather than have an isolated patellofemoral arthroplasty. It's relative contraindication to do a patellofemoral arthroplasty in an obese patient above 30 degrees because of the higher failure rate. And thank you so much. And sorry, it's quite long, but I have to finish the whole total knee technique designs and how to do it. Hopefully it was useful, and hopefully you got every point. I'm very happy to answer any of your questions if you have any. I hope I went through it systematically and you got most of it. Be careful about soft tissue balance. Be careful, very important. Be careful about your component rotation, especially the femoral component. Be careful about your patellar mat tracking. Never get your patient off table with a patellar mat tracking. Range of motion, try to get the best range of motion for your patient, but you can accept a bit tighter range of motion or loose range of motion rather than hyper mobility or hyper extension. You can accept a bit of flexion deformity. You cannot accept a hyper extension. And this has been explained in details in the second lecture. So hyper extension is not acceptable. Flexion you can accept. So if my range of motion will be limited, I can accept a limited extension, not a limited flexion. What can you explain? What is the medial referencing in valgus knee? Yeah. So we cut the femur, we cut the distal femur, and now we planning the rotation. Yeah. So we plan the rotation based on epicondylar axis between medial and lateral. Yes. You cannot use that in a valgus knee. White side line will be the same, and you do a medial referencing rather than a lateral referencing. So rather than get an epicondylar axis, you get only a reference point from the medial epicondyle till it becomes perpendicular on the white side line, and this will be the reference for rotation of your component, because the lateral femoral condyle is hypoplastic. So actually the epicondyle is not in place. So rather than it will be parallel to the rotational axis of the femur, it will be like that. So don't depend on the lateral femoral condyle at all. So if you're planning your rotation in a valgus knee, when you know there is a hypoplastic lateral femoral condyle, use a medial reference point, which is a medial epicondyle, draw a line which becomes perpendicular on the right side line, and this will be the reference for rotation of your femoral component. So don't depend on the lateral side, either in referencing mediolateral or anteroposterior. So you depend on anterior reference, not posterior, because the lateral femoral condyle is gone. And medial referencing when you're doing the rotation, not a lateral referencing, not a transepicondylar, because the transepicondylar will not be correct because the lateral femoral condyle is hypoplastic. Clear, Ziad? Any other question, guys? So once recording is ready, it will be on the YouTube channel. You can listen to it many times. Hopefully it was clear, and hopefully I send you the messages I want to send. You will find the knowledge everywhere is the point to give you bits of tips and tricks, and what should you do, what should you not do. You receive a feedback after the lecture. Hopefully all of you will fill in it. I'm very happy to hear your voice, positive or negative. Everything will be taken on board, aiming to improve the next sessions and next lectures. Next lecture hopefully will be in 2 weeks' time on a Friday at 9 p.m. London time. And I wish I see you all there. Thank you so much for attending today and for your time.